Hello. Hi everyone, my name's Ashish Khanna, and I'm happy to be a part of our symposium today. I'll be speaking on breast cancer related fatigue. This is a brief overview of a common, very common, I would say, syndrome. I believe I've been introduced already, but if not, I am the Director of Oncology Rehabilitation at the Winship Cancer Institute at Emory University, located in Atlanta, Georgia, in the United States. I have no disclosures. So let's talk about cancer-related fatigue. I think the most important thing to remember here is that cancer-related fatigue is the most common complaint among cancer patients. All right, so this is an important topic, you might say. I think we're all familiar with fatigue. I think we've all felt like this gentleman here looks. And that's what I call your standard Monday morning sort of fatigue that we're all familiar with. But it is important to remember that in cancer-related fatigue, it's different. Cancer-related fatigue is not your standard fatigue. All right, so let's talk about why. Let's go through what is the definition of cancer-related fatigue. First thing, most important thing I would say is it's a fatigue not relieved by rest. So most of us, when we feel like that guy in the previous slide, what do? We lie down, we take a nap. When we wake up, do we feel better? Yeah, we feel a lot better after we take a nap. We feel refreshed. In cancer-related fatigue, that's not the case. Patients are going to be tired. Many of them, going to take a nap, whatever the case may be. They wake up afterwards and they feel about the same as they did before their nap. So it's a fatigue not relieved by rest. Next important point, it's a fatigue that's out of proportion to exertion. Right, so many of the patients will feel completely wiped out just walking down to the mailbox or taking out the trash. Things that never really used to bother them at all will become physically exhausting to them, and they'll feel like they need to sit down, or in some cases even take a nap after doing something that they could have easily done prior to their cancer journey. These two are the most important differences, I would say, and hopefully you all can remember that. That's something that I always ask patients, because these are the two criteria really for cancer-related fatigue, and like I said, how it differs from your standard fatigue. If we're going to diagnose cancer-related fatigue, we want to make sure that it's not associated with distress and functional loss. It also has to be, it has to be associated with distress and functional loss. It has to have a clinical association with a cancer diagnosis and/or chemotherapy, of course. And it cannot be explained by a primary psychiatric diagnosis, for example, depression. All right. So, cancer-related fatigue is one of the most common and distressing side effects of cancer diagnosis and treatment. It is a persistent, often overwhelming feeling of physical, mental, and/or emotional exhaustion. CRF can affect people with cancer at any stage of the disease and at any time in the cancer trajectory, from diagnosis through long-term survivorship. Unfortunately, it can persist for years. Excuse me. So let's talk about the prevalence. About a third to maybe half of patients, 30 to 60% of patients, experience moderate to severe fatigue during treatment. So almost everyone will experience some sort of fatigue. And then a quarter to maybe a third of them continue to experience fatigue for months or years after treatment completion. So this is tragic. What is the significance? Well, this is an interesting study. It's a very old one now. It's from 2000. But I think it kind of illustrates, it kind of tells us a lot about this particular issue with cancer patients. This study, they looked at 538 cancer patients, and they did a survey of patients and the oncologists. Okay, so in the oncologist's view, pain is more clinically relevant than fatigue. Right, so that's what the oncologist said, right? And that's how, and that would include us. Some people on here may be oncologists, some may not be. But just as healthcare providers in general, I think it's fair to say that we ask about pain a lot, right? That's how we're trained. What's your pain? 1 to 10, 1 to 10, 1 to 10. That's all we ever ask. How's your pain? We never ask nearly as much about fatigue. So we ask much more about pain. If you survey the patients think that fatigue actually affects their everyday life much more than pain. All right. 52% of the patients never even reported fatigue to their oncologist, perhaps because they weren't asked. Only 14% of them had received treatment or advice on how to manage fatigue. And about a third of the patients with fatigue declared that they felt like they had not received adequate treatment at all. All right, so we're not asking. What causes fatigue? All right, so let's talk a little bit about what causes it. There are the demographic factors: age, income, marital status. We have the psychosocial factors: depression, catastrophizing, coping style, that can contribute to fatigue. We have the health behaviors, the degree of physical activity that they have, their degree of cardiopulmonary fitness. We have comorbid symptoms. Are they in pain? We have menopausal symptoms. Sleep disturbances, as you might imagine, can impact fatigue. We have comorbid medical conditions. There's cardiovascular diseases, pulmonary issues. BMI has been shown to factor in. And then lastly, last but not least, we have the biological factors such as anemia, right? Many of the patients, particularly with blood cancers, are going to be anemic. Or just, all cancers really have some degree of, and almost all of them. And then the other biologic factor here is inflammation. And inflammation, this is one of the big take-home points of this talk. So I'm going to spend the next couple of slides talking about inflammation. So what is inflammation? Inflammation is the body's response to infection or injury. It's mediated by pro-inflammatory cytokines. So we have IL-1, IL-6, and TNF-alpha in particular. And these have local and systemic effects, and importantly, these include effects on the central nervous system. This was a great article in the Journal of Clinical Oncology from 2008, talking about the neuroendocrine immune mechanisms of behavioral comorbidities in patients with cancer. So I'll draw your attention to the left column here. We see cancer and its treatment, right? We have the tumor, the metastases, chemotherapy, the psychological stress, surgery, radiation. What does all of that do? Follow this blue, I'm not sure if you can see my arrow. This blue arrow here takes us to inflammation. Again, like I said, inflammation, increase in pro-inflammatory cytokines, right? We have increase in adhesion molecules, acute phase reactants. That's going to impact the sleep-wake cycle, decrease sleep efficiency, a more awake time, increased latency to sleep, and disrupted sleep rhythms. What does that do? That would in turn impact the neuroendocrine system. So we have flattened cortisol slopes, decreased glucocorticoid sensitivity, as well as decreased cortisol responsiveness to stress. What does all of that do? Leads to an increase in inflammation. So you can see we have a cycle here where we go around and around and around. Ultimately, that increase in inflammation, which kind of feeds on itself, like we just said, impacts the central nervous system, including changes in the different neurotransmitters, serotonin, dopamine, those kinds of things. Ultimately, we see in the right column, the light blue, that results in behavioral alterations, and you can see here that inflammation here would ultimately lead to fatigue, as well as depression, impaired sleep, and cognitive dysfunction. Right, and those are all things that we see in breast cancer patients with fatigue, or all cancer patients with fatigue. We see depression, impaired sleep, and cognitive dysfunction as well. So cancer-related cognitive impairment, right? That could be its own talk. It is its own entity. And inflammation does contribute to that as well. This is a similar kind of topic, a similar slide, a different picture, where we talk about tissue trauma, how that impacts inflammation and causes a central nervous system response. So here we see all the different cancer treatments. Results in, again, increase in IL-1, IL-6, and TNF-alpha, or tumor necrosis factor alpha. Ultimately, it's going to impact the serotonin and dopamine in the brain. And these effects of the central nervous system include decreased appetite, decreased energy, decreased social activity, sleep changes, impaired learning, memory, soreness, pain, as well as fever. right? We have some studies demonstrating for a fact that TNF alpha is increased by chemotherapy. This was a prospective longitudinal observational cohort study here of early stage breast cancer patients. That's why I included it here. They were recruited at the end of initial treatments. The primary treatment exposure included surgery, plus or minus radiation, and plus or minus chemotherapy. And here it was prior to the initiation of adjuvant endocrine therapy. So chemotherapy here, we have the amount of TNF alpha on the y-axis here. On the x-axis, we have time. You can see by the dotted line chemotherapy here that the chemotherapy resulted in increased TNF alpha or inflammation at all time points. And actually, it even remained slightly elevated 1 year later. So even at 12 months, we can see that patients with chemotherapy had higher degree of inflammation, higher markers of inflammation. So how does these cytokines impact the brain? As TNF alpha declines, we actually see improved prefrontal activity. So you can see, there's a lot going on this slide. I'll just direct your attention here. So we can see chemotherapy here, patients with high TNF alpha at baseline, and those patients with low TNF alpha at baseline. You can see here with the red arrows, this is the inferior frontal gyrus. Here has decreased activity in the brain as compared to those with low TNF alpha. And similar situation at 1 year follow-up. This is just sort of an interesting thing, aspect of cancer-related fatigue and inflammatory component of it, demonstrating that there is a genetic component as well. So that we see here an association between 3 individual SNPs, or single nucleotide polymorphisms, in the promoter region of the cytokine genes, and the severity of fatigue and cognitive complaints at baseline. So we do have a genetic component, and that genetic component is actually additive. So we can actually make a genetic risk score for these SNPs here. So you can see the patients with more high expression alleles have more severe fatigue and cognitive complaints, and the genetic risk index that they made for this study is significantly associated with greater fatigue and cognitive changes. So we can actually calculate the genetic risk of an individual to develop fatigue as a result of our treatments, meaning that the day might soon come where we can actually use a genetic test to predict the risk of someone getting fatigue, right? And that's the part of the future of personalized medicine, which is very exciting. And maybe we could intervene earlier in these patients with a higher genetic risk score. All right. So what can we do about it? How do we treat cancer-related fatigue? The first and most important thing is to identify and treat the underlying factors. We want to treat depression yeah, that's fine. I won't get into it. Physical symptoms such as sleep disturbance and pain, and then we want to treat anemia, and then the other medical conditions, underlying medical conditions. Let's take a look at that in more detail, sort of in a flow chart. Makes it sort of easier to understand. At the top is the focus history. We want to talk about the disease status. This is the primary evaluation of at the initial visit of a patient with fatigue. We want to do the focus history. We want to look at the disease status and treatment. We want to consider recurrence and or progression. Then we're going to take a review of systems, followed by an in-depth fatigue history. A history of fatigue includes the onset, the pattern of the fatigue. For me, pattern means when do they feel the most fatigued. Just in having done this for a couple of years, I find that to be sort of early afternoon when patients feel like they crash. So that's a pattern there. Sometimes people crash later in the evening as well, so that's important. the duration of how long have they had the fatigue, and then the change over time, or the trend. Is it getting better? Do you feel like it's getting worse as time goes on? Then we have the associated and alleviating factors. What makes it better? What makes it worse? And then, as of course physiatrists, we're interested in how that interferes with their function. I would also add how that impacts, of course, their quality of life. And then, as clinicians or as physicians, we want to assess for treatable contributing factors, right? So, for example, if somebody's hypothyroid, that would be something easy for us to test and check. And how tragic would it be, if somebody was fatigued and, they were hypothyroid the whole time and no one ever checked, right? So that's the kind of thing that we want to do. And that's why I kind of put this in red and made this slide. Let's start at the left and go to the right. Medications and side effects. We want to take a look at that. Many of these patients have, there's a lot of polypharmacy happening. Some of it probably necessary, some of it probably not. In some cases, medications like gabapentin or sedative medicines like gabapentin. Then we have other like opioids, which I guess goes kind of sort of more with the second bullet point there with pain contributing there. So we want to try to see what is the patient taking medication-wise that may be contributing to the fatigue, and can we change those medicines or speak to the person who's prescribing them about maybe switching to something a little less sedating. There's also pain, like I said, inadequately addressed pain, emotional distress. Can be addressed by our wonderful colleagues at the cancer center where I work, our palliative care, supportive care, and then the religious folks as well do a wonderful job. Then we have, are the patients anemic? Spiritual health, sorry, that's what I was trying to think of. Spiritual health folks do a wonderful job. Then anemia is another one. Many of the patients are going to be anemic naturally, particularly those with blood cancers, liquid tumors. Then sleep disturbance and poor sleep hygiene. Next, I always sort of discuss their nutrition. How well are they eating? Are there any deficits in nutrition or nutritional imbalances? And then their decreased functional status, it's important. And then any other sort of comorbidities, right? So hypothyroid, I guess, would file under here. Under other comorbidities, do the patients smoke? Are there other things contributing? Pulmonary hypertension, things that are, did they have a pneumonectomy for lung cancer? Those kinds of things can impact, for example, cardiovascular fitness and those things. So you need to do kind of a thorough chart review and see if there's, maybe the patient may benefit from cardiac rehab, something like that. All right. So now that we've established all that, what are we going to do about it? Right? Nothing. No, just kidding. We have a couple choices. Pharmacologic, we have psychostimulants are going to fall under that category. We have behavioral or psychological options. Exercise is one. Psychosocial interventions, and then I'm going to speak a little bit at the end about complementary and alternative medicine, and what do studies show about those types of interventions. We'll start with the big one. Many of you probably already know what the best treatment for fatigue is, and that is going to be exercise. Telling a patient to exercise is, so one of the patients told me that when I told them the best treatment for fatigue is exercise, they told me that that's absurd. Right, I'm fatigued. What do you mean you want me to exercise? That's the most ridiculous thing you could possibly say in this situation. And I, you know what? To be honest with you, I sort of agree, because I'm not even fatigued and I have trouble exercising. So telling somebody to exercise when they're fatigued is sort of a tricky situation. But that, as clinicians, that's what we have to sort of use our finesse and personal interaction skills to deal with. This is a study that just came out this year. That's why I included it. It's management of fatigue in adult survivors of cancer. This is from the ASCO Society for Integrative Oncology guidelines update. So let's talk about that. What did this committee find? They reviewed, what did they do? So first they reviewed trials of diverse exercise types administration methods, different exercise schedules. Naturally, there were challenges in determining what is the optimal duration, the optimal frequency, what intensity for exercise programs are we looking at during cancer treatments. This wide range of all of these types of things, as there always is in exercise research, right? However, ultimately, they found that, quote, in totality, the current evidence supports the efficacy of exercise for cancer-related fatigue across diverse modalities and settings. Their findings, which I'm going to outline again more towards the end, I'll give you guys a table of those findings to make it sort of concise. Their findings are consistent with several systematic reviews and meta-analyses that have been done in the past, over the past few decades, as well as the recent guidelines, right? So the NCCN has some guidelines. I didn't include all that on fatigue. There's a lot of different organizations, a lot of different folks out there recommending, once they review the literature, agreeing with these agreeing with the exercise interventions in general. But specifically, what can we do? That was addressed. Most people will point to the American College of Sports Medicine 2019 roundtable. And these folks found that moderate intensity aerobic exercise was the best intervention, and that was for a minimum of 3 sessions per week. Okay? This is a combination of aerobic exercise and resistance training 2 to 3 times a week. And the resistance training was done twice. They recommend resistance training to be done twice weekly. So here's what I tell the patients, right? So let's break this down. This is what the research shows us. This is just me. How do I discuss this with folks? I tell them that anytime that we're talking about exercise and we're doing an exercise prescription, say there's going to be there's always a dose, let's say, of exercise and an intensity. So what's the dose and intensity based on what we just discussed? It's 150 minutes a week of moderate intensity aerobic exercise. Okay, that's 30 minutes, 5 days a week. Most people can achieve this with a brisk walk. Okay, so you can walk to reach this moderate intensity. But what is moderate intensity, right? We're going to I don't give people heart rates because I find people, they look at their watch and, they're trying to reach some target heart rate. What is moderate intensity? To me, moderate intensity means where you're exercising to the point where you're huffing and puffing, but you can still carry on a conversation, right? So you're short of breath, but you can still talk. So that's what I tell folks. I tell them if you can do 150 minutes, again, 30 minutes, 5 days a week of brisk walking or any other sort of exercise that gets you sort of short of breath, but you can still talk, still hold a conversation, that is the target, right? And then on top of that, per the previous guidelines, 2 days a week of strengthening exercises or resistance training as well. So ultimately, I tell patients, you are the future. You are the future. You are the medicine for fatigue. I'm getting fatigued after talking here. Clearly. All right. So for folks who are fatigued and for folks who are fatigued of giving PowerPoint presentations, we have the psychostimulants. So let's talk about the pharmacological interventions here, okay? So psychostimulants are the most common pharmacologic interventions studied. These stimulants are particularly methylphenidate, the most studied, do show some evidence of efficacy in reducing cancer-related fatigue. But the overall size is modest and further high-quality trials are needed to establish their role definitively. Modafinil, also known as Provigil, and methylphenidate, known as Ritalin, at least in the United States, those are the most frequently studied. The systematic review and meta-analysis by Minton in 2011 is often cited. This found preliminary evidence supporting the use of psychostimulants, particularly methylphenidate, in treating cancer-related fatigue. Statistically, this really just ended up showing a modest benefit over placebo. There was another more recent meta-analysis by Gong in 2014, Gong et al. 2014, suggested a therapeutic effect also of methylphenidate, although the evidence here, again, limited, and further, the authors felt that further confirmation was needed. So let's talk about the future again. I always like to include future things in talks because I found that they're exciting. What about the pharmacological intervention of anti-cytokine therapies? As we discussed, cytokines play a large role due to inflammation and play a large role in fatigue and sleep-wake cycle, all the things that we had talked about previously. So why can't we just find some anti-cytokine therapies? Well, you're not the first person to think of that. A few people have looked into it already, which is wonderful. So there is the potential intervention, like I said, for managing cancer-related fatigue given the role of pro-inflammatory cytokines in its pathogenesis. Increased activity, again, IL-1, IL-6, and TNF-alpha have been implicated, and so therefore it would suggest that targeting these cytokines could be beneficial. However, the evidence, unfortunately, supporting the efficacy of these anti-cytokine therapies is still emerging. It's still somewhat limited. And that really is because it's not that straightforward, right? As you might imagine, cytokines, just like the endocrine system and all the different ways that the body transmits signals within itself, it's a very complex and multifactorial etiology. Some studies have shown that blocking IL-6 signaling can mitigate certain metabolic and inflammatory responses associated with fatigue, and others have found that fatigue can really develop independently of IL-1 signaling completely. So it's a complex process. It's further complex because the more acute effects of cancer treatment causing fatigue, patients are undergoing chemotherapy. When they're getting the radiation, they are fatigued. But that's not likely is not the same process through which patients experience fatigue 1 year later or 2 years later, right? So even though they still feel fatigued, the pathogenesis here, or the etiology, or the exact mix of factors is going to be different in the acute phase versus the long-term phase too. So a very complex issue. The anti-cytokine therapies, I believe, are largely the medications that we recommend for rheumatoid arthritis, for example. So current data suggests that while cytokine antagonists may hold some promise, at the moment their clinical utility remains to be fully established, right? But we'll keep our fingers crossed. Because again, asking patients who are fatigued to exercise it can be a huge ask. Other interventions, we can talk about the psychological interventions as well, cognitive behavioral therapy specifically. This has been. Let's talk about how that works in severe cancer-related fatigue. So CBT, or cognitive behavioral therapy, has demonstrated significant benefits in reducing cancer-related fatigue. This conclusion is based on multiple randomized controlled trials and that consistently show statistically and clinically significant decrease in fatigue levels in patients receiving CBT compared to those in usual care or waitlist control groups. Cognitive behavioral therapy, how does it work? In this case, it addresses fears about recurrence, maladaptive coping or catastrophizing, dysregulated sleep and activity patterns. Again, poor sleep hygiene is very common, especially people, including myself, looking at your phone, etc. In the middle of the night, way too late, scrolling, poor social support, etc. So that's really how this works. And this comes from a study here that was just published a few months ago in July 2024. And I suggest you, if you're interested in this, take a look at this. It's called Management of Fatigue in Adult Survivors of Cancer, the ASCO Society for Integrative Oncology guideline updates. In that study, they looked at other interventions as well. I have put those on the left side of the screen. In the second column, we have the evidence quality, and then on the right, what this group thought what the strength of the recommendations were. So here at the top, we have exercise, we have moderate evidence quality, and so with a strong recommendation. Probably, again, exercise has shown to be the best treatment for fatigue. Yeah, that's fine. Okay, so then we have cognitive behavioral therapy as well. I was going to say about the exercise, one of the best things that we can do, in my opinion, for the patients is if we're going to ask them to exercise, we want, and if, giving them a vague, you need to exercise more frequently doesn't work. Coming up with a personalized or customized exercise program works fantastic. And for me, at least, the best way to do that is to refer to the exercise professionals, our physical therapy and occupational therapy colleagues, of course, who are wonderful at developing. We want to reach 150 minutes a week of moderate intensity exercise, and our therapy colleagues would be able to help the patients reach that goal slowly over time. Right? We're not going to do that overnight. And also the other benefit would be a lot of these patients have other aches and pains or other barriers to exercise that our wonderful therapists can address as well, meaning pain or joint pains, things like that. So I lean heavily on our PT and OT colleagues when it comes to helping patients reach that goal of 150 minutes a week. There's also the cognitive behavioral therapies, another strong recommendation. We have the mindfulness-based programs, another strong recommendation. Yoga and acupressure, we have low-quality evidence with conditional recommendation. I do, sometimes bring that up. And then the stimulant medications, we have moderate evidence quality with those. So the strength of their recommendation here, again, is conditional. Other ones, we have insufficient evidence, and then this group was unable to make any recommendation for or against. These include acceptance and commitment-based or attention-based interventions. Acupuncture, interestingly, acupressure achieved a higher strength of recommendation than acupuncture on their review of the literature. Bright light therapy, ginseng, I think specifically, some people recommend American ginseng. Which of course you're welcome to still do. Just this group here found the evidence to be insufficient for that. Mistletoe, omega fatty acids, psychoeducational interventions, self-management, health apps, which I've seen some people do wonderful with. And then there's Tai Chi or Qi Gong. I think it's how you pronounce that. Apologies if that's not how you say that. So these are the different interventions that we have here and the strength of their recommendations. And that's about it for me. I'll leave this slide up here for a couple minutes. Let you guys take a look and let me know if you have any questions. Actually, I'll go to the next slide. My email address is on this next slide here. So you guys let me know if you have any questions about this. That's my email address in the bottom left corner. Thank you guys very much.